Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer-reviewed and free. I'm Dr. David Liu, your host for this episode. Today I'm speaking to Dr. Chamara Basniake, a gastroenterologist at St Vincent's Hospital in Melbourne, and we'll be discussing his article in the October 2018 edition of Australian Prescriber on the treatment of irritable bowel syndrome. Chamara, welcome to the program.
Thank you for having me, David.
So, irritable bowel syndrome, IBS, seems to lead to a lot of confusion amongst patients and amongst some clinicians as well. So, what's this enigma of a disease? Talk me through it.
I mean, I agree with you. This is the issue. There's a lot of confusion with patients about this condition. What irritable bowel syndrome is essentially gut symptoms in the absence of traditional anatomical or biochemical abnormalities. Now, of course, if we were to cut open people's intestines and look under a microscope and look at their microbiota, it would be definitely abnormal and different. Nonetheless, based on the traditional medical testing, you wouldn't find any abnormalities. Now, the key thing about irritable bowel syndrome is it is the gut symptoms related to your large intestine, we traditionally think of it as. It's characterised by symptoms of discomfort or pain related to defecation. And it can be of one of 3 or 4 subtypes. But we typically describe it as either a diarrhea predominant or a constipation predominant. But I think the key point is finding what is the specific contributor to one patient's symptoms and specifically targeting that, rather than using treatments as a blunt tool for all people with all functional gut disorders.
How would we go about in terms of a diagnostic approach to trying to make a diagnosis of irritable bowel syndrome and being able to go about treating it?
You can diagnose it on the basis of simply the symptoms alone. And in a patient without red flags, that's enough.
What should we be looking out for? Which patients should be referred for colonoscopy and which patients should be directly treated for irritable bowel syndrome?
Well, irritable bowel syndrome should not cause bleeding. And so anyone who has bleeding, that should warrant an endoscopy. Anyone who has new gut symptoms above the age of 50, we say, or in fact anyone who has a significant family history of an organic gastrointestinal disorder, whether it be young family members with cancer or inflammatory bowel disease, that would also warrant at least a specialist evaluation. You shouldn't get an iron deficiency anemia. That would also warrant endoscopy or at least a consideration. And patients shouldn't lose weight either.
I can imagine, though, that the majority of IBS patients don't have any of those red flags, and the majority could initiate treatment with their primary practitioner?
That's absolutely correct. Now, the difficulty, though, is many primary practitioners in particular will always have that sense of anxiety. Well, am I missing something here? Is this the patient with Crohn's disease that I'm ignoring? And one way you can delineate that is just to simply do some basic blood tests to see if there's any biochemical abnormalities, or performing a test called a fecal calprotectin. That's a feces test which measures a particular marker, calprotectin, which is indicative of intestinal inflammation. And if that's abnormal, well, then that would warrant a specialist to review the patient.
Yeah, that's certainly reassuring for someone like me. How would you recommend that we approach the treatment of IBS?
So I think that the first thing is to give the patient the diagnosis and be very clear about it. And that is to tell them that the condition is irritable bowel syndrome, and to explain that the condition doesn't lead to cancer or doesn't lead to any major organic catastrophe. So that's number one. And the second thing is to explain why they have these symptoms and to explain that it's in fact a very common condition in the community. And then the next step is to address the concerns of the patient. Well, I think it is worthwhile asking the patient whether or not they want treatment. Some patients are satisfied to have the doctor explain to them that nothing is wrong. For the patients that need treatment, it is an adequate history and examination to determine what the contributing factors are. So, for some patients, I can give you an example. I had a patient a month ago who was consuming 1 kilogram of sauerkraut a day because they thought it would promote a healthy gut bacteria. And clearly, that was contributing to their symptoms. When we told them to stop that, 80% of their symptoms had been relieved. If you take an appropriate history, you can determine both from a dietary history, a toileting history, and even a history of other psychosocial contributors, there may be certain things that need to be targeted with a particular response.
Where do we go from there? What's the role of dietary intervention? What are the roles of medications in IBS?
Yeah. So, I think if a patient wants to be treated, usually I think a dietary intervention is an adequate and appropriate first step. So the two diets that we would typically prescribe for this is a low Fodmap diet or general dietary advice. And in the article, I explain what's called a NICE diet, which is the National Institutes of Clinical Excellence diet from the United Kingdom. And that's mainly a very sensible diet which cuts out major contributors, including caffeine, alcohol, and certain foods which may trigger gut symptoms. So just a sensible approach. So when you have a patient in front of you and you want to advocate for a dietary manipulation, if they have diarrhea-predominant irritable bowel, then I think a low FODMAP diet is an effective strategy. What it involves is a patient usually seeing a dietitian, and that's what we would recommend, who would then explain what FODMAPs are. So these are poorly absorbed carbohydrates. They would ask the patient to reduce, not completely cut out, these poorly absorbed carbohydrates, and then review the patient in 6 weeks. If there has been an improvement in symptoms, the dietitian will then carefully reintroduce foods that the patient is less likely to have symptoms from. And eventually a patient will be within a space where they've only just reduced the foods that cause them the most problem. There is resources on the Gastroenterology Society of Australia, or GESA. So if you just Google GESA low FODMAP diet, there's a basic printout of what's involved.
Right. So what about the patient who doesn't get the relief that they want from a dietary approach? Where do we go in terms of medications?
So I think with medications, the tried and true medications that we would use for functional gut symptoms, in particular irritable bowel, are a low-dose tricyclic antidepressant. So it seems to reduce the severity of the pain, and in particular diarrhea-predominant irritable bowel, you will find patients they'll go to the toilet less frequently. Now, it is critical that you tell the patients that it is not used to treat depression. So what I would tell a patient is, this is a drug which I'm using to improve pain and improve the contractility of their gut. I explain to them it's a medication that we use regularly, not on an as-needed basis, that they take it at night time, that the low dose is unlikely to have side effects, and we review them 4 to 6 weeks after starting it. It takes about that long before there's been an adequate effect. If a patient doesn't want to take a medication on a regular basis, that's a perfectly reasonable response, in which case, if you've excluded dietary therapies and excluded medical therapies, you're left with behavioural or psychological therapies. What we have seen in studies is that short-term cognitive behavioural therapy in fact reduce symptoms for patients with irritable bowel syndrome. And that's definite and that's significant, and that's been repeatedly seen in studies. Now, we think the mechanism of that is addressing some of the hypervigilance, visceral hypersensitivity, and sometimes abnormal behaviours seen in patients with irritable bowel syndrome, especially severe forms. So it's in fact not harnessing a placebo response, but it is treating the sort of nervous imbalance in patients with irritable bowel syndrome. If I could make a separate point about a placebo effect, we know that there's a significant placebo response in patients with irritable bowel syndrome. And in fact, if you're just simply warm and empathetic and promote a positive response in patients, these are the patients who are most likely to have effective treatment of their symptoms.
Speaking of that potential placebo effect, where do probiotics fit in all amongst this?
Overall, I think it is probable that probiotics have a positive effect in irritable bowel syndrome, but the effect is very modest. The issue is the studies all use different strains and at differing doses, and the exact strain and dose can't necessarily be easily found in the pharmacy. So it's hard for me to translate the studies into an adequate strain and dose for clinicians to use. But it probably works, and if a patient feels better as a result of taking it, I in my practice, and certainly a lot of my colleagues, wouldn't stop a patient from taking probiotics.
What about Refluxmin? Where does that sit in the algorithm? Does that really work like an antibiotic, or is there something else going on?
The theory is that there is a microbial disturbance in some patients with irritable bowel syndrome, and that a particular microbial profile contributes to improper immune and pain-related signaling, which then contributes to their symptoms. Some of the trials in this area have shown that there is a benefit of taking Reflux over placebo. I should say two things. One, the effect size on a patient appears to be modest compared to placebo. The second thing is rifaximin is not subsidised under the PBS for this indication, so patients will be paying out of pocket. 3, it's only really been examined as a treatment over 2 weeks, and then patients are followed up a month later. The issue with rifaximin is there's no exit strategy, unlike the low Fodmap diet, and unlike, say, a tricyclic, which we would typically de-escalate over a year. A particular therapy we haven't touched on, David, is gut-focused hypnotherapy. I do want to just mention that briefly because in Australia, there was a trial that examined a low Fodmap diet against a gut-focused hypnotherapy. So a psychologist then puts a patient into a state of hypnosis, then through persuasion treats gut symptoms and symptoms of comorbid symptoms of anxiety, if they're there. We've found that patients who undergo this particular therapy are just as likely as patients with a low Fodmap diet to have pain and bloating symptoms reduce. And more importantly, when you examine these patients 5 years down the track, 70% of them still have adequate relief of their gut symptoms. So psychological and behavioural therapies are really quite effective. It's just unfortunate that they're not easily available. So if you're a patient and you've tried a few different things, including diet, maybe some medications, it might be worthwhile seeing a specialist to potentially see whether or not you'd be applicable for this type of therapy. And I should make a final point. There are multidisciplinary functional gut clinics that manage irritable bowel syndrome in Australia. And these are clinics where the gastroenterologists work alongside dietitians, gut-focused hypnotherapists, pelvic floor physiotherapists, and even psychotherapists.
Chamara, that's been a fascinating insight into IBS. Thanks very much for joining us on the podcast.
Thanks, David.
The views of the hosts and the guests on this podcast are their own and may not represent Australian Prescriber or NPS Medicine Wise. I'm David Lear, and thanks once again for joining us on the Australian Prescriber podcast.